Okay, so we're now hosting our third Vancouver Health for All Network meeting in follow-up to two previous launch meetings that we've hosted over the last couple of weeks. We are now thought it would be helpful to share about a framework that we've been developing out of Vancouver Community College School of Nursing within our population health practicum to support our students in aligning and integrating health promotion practice within their frontline nursing practice. We thought we would offer that as a framework that we could explore and as a really a point of dialogue to engage interdisciplinary health and social service providers and our wider civil society partners to explore how we can integrate and align the recommendations within the Ottawa Charter and various frameworks of health promotion within our work on the front lines, and to integrate that work with community partners and Indigenous nations and their leadership in addressing the determinants of health across our communities here in the unceded territories of BC. So as mentioned, I'm going to share this framework teaching tool also as an invitation to Health for All network members to join me in developing it into a more formal framework to guide the integration of health promotion within frontline interdisciplinary health and social service practice. And so far, Abe Outshorn, who is an assistant professor within the nursing program at Western University, and Kaylee York, who's a public health nurse in the interior of BC, have agreed to join me in this work. And we're planning to engage in a more formal lit review to further develop the framework. And they're here today to listen in and join our dialogue later. And Abe will be joining us mid-June to share about his work out of the Center for Research on Health Equity and Social Inclusion out of Western University, and some of the ways that the center supports local community organizing and health equity advocacy, which will segue into exploring some possible participatory action research projects that we may engage in here in Vancouver to support the integration of health promotion within frontline practice and community-based health promotion initiatives. So I'm going to share some reflections here over the next series of slides. I'm not going to take up much more than, I'm hoping, 15 minutes to just share some high level kind of thoughts, reflections on how we could look at engaging all health and social service providers in this health promotion work. I was looking this morning at a Canadian Institute for Health Information report on, how many, and the question coming to mind was how many nurses, doctors, health workers, social workers, all of the various different disciplines are there working in Canada. And using nursing as an example, we have 431,769 nurses in Canada. So that's a large group of members that I think, among other interdisciplinary health and social service providers, that would be amazing to be looking at how we can engage them in this health promotion work in all spheres of our interdisciplinary practice. So this is definitely something we've been contemplating at VCC in our population health practicum with our nursing students. And I know that other health science programs have variations on that and developing their practicums and educating interdisciplinary students within these concepts. And I am curious, and this is something that we've talked about with our working group here in BC, is wondering if we might look at surveying the health science programs across BC and looking at how is health promotion, population health being taught, how are their practicums being developed, and what are the issues, barriers, and opportunities for strengthening that, which has been identified, and I'll share in a moment. There's been several reviews that have been coming out over the last, I would say, 5-6 years, looking at the barriers and opportunities to health equity-oriented advocacy, and one of the key barriers is education. So I am curious, I've just put a couple of slides up that to frame this sharing. The 1978 Alma Ata Declaration, where we had, I think it was about 134 nations that were represented in Kazakhstan, to take a step back from healthcare systems and looking at what are the issues there and how to be developing health systems from an equity and social justice perspective. Out of that, there were a list of principles, of primary healthcare principles that were developed, one of which was the notion that we really need to be shifting and reorienting existing health systems upstream to be engaging in primary prevention and health promotion. So these are some of the principles. In our conversation later today, I'm very curious about if those are being introduced in other health science programs like social work and occupational therapy, dental hygiene. We also then have, late 80s, There were international conferences and gatherings that were happening. The Ottawa Charter for Health Promotion was envisioned and developed at that time, and working to develop a model of promoting health from a social determinants of health perspective. On the right side here is the Hamilton and Body model that is posted within the Public Health Agency of Canada's website. And these are two models that we use as central pillars, foundations of the work that we do in our program. And I'm curious what other programs are doing in terms of educating students about health promotion work. So this is, I've just pulled this slide. There's different models too that have been developed. This is Leslie Dyke and Nabumian Ayoe of the National Collaborating Center on Determinants of Health, pulling together that literature and developing frameworks on policy advocacy and the various levels of health promotion that we can be engaging in. And so we've been taking these various bits of literature in developing a framework to guide our population health practicum at BCC, which I'm going to share with you all in a moment. And I'm very curious if there are folks online, in addition to Abe and Kaylee, who have graciously offered to join in this work of reviewing that literature and looking at perhaps developing a framework that can guide interdisciplinary health promotion work in collaboration with those more formal positions that we hopefully are going to be continuing. Well, I think we've had positions that have been cut back in our health systems that are focused, that are dedicated positions on health promotion and community development. And we need to bring those back and then expand them. And then how do we work across those positions, as well as our civil society partners that are engaging in upstream health promotion work through their advocacy on determinants of health in collaboration with frontline health and social service providers. That's a burning question for me increasingly. How do we support frontline health workers to be engaging in this work? So I'll share with you all about that in a moment, just as food for thought for our discussion. But I wanted to start off by just acknowledging nursing as an example. And again, I'm very curious to hear what some of the issues and barriers and opportunities are in other health science programs. In nursing, we have a long history of engaging in upstream health promotion work. Public health, community health nurses used to have scope within their practice to be engaging in community development and organizing work historically. And this piece here, The Origins of Public Health Nursing, speaks to that. We also have several professional practice documents. This one, the 2019 Community Health Nursing Professional Standards of Practice, has come out this last year. And that was as a result of consulting with over 500 nurses across Canada to look at what are the basic competencies for community health nurses. And in that, they work to strengthen the Ottawa Charter language, also integrating Indigenous ways of knowing. And of the 8 standards, 4 of them are focused on, one of which is on health promotion, one on prevention, one on community capacity building, and one on health equity. So they've really strengthened that language and that acknowledging the importance of upstream primary prevention and health promotion work. Now, whether or not they're able to apply that within their frontline practice is an increasing issue. And so these documents to the right speak to the whittling away and the increasing cutbacks that we've faced over the last 30 years of neoliberal and austerity politics more broadly. This Ontario report, I'm not sure if Abe, you've had a chance to have a look at this, looking at public health nursing in school settings, have suggested that there's been this broader shift from community-focused nursing to program-focused nursing. And again, this narrowing of scope of practice. So I won't get into these studies here, but just to acknowledge there's some important work looking at the narrowing scope of practice that have been happening in nursing. And I'd be very curious to hear about other disciplines and their challenges and opportunities in doing this work. Now, we also see this parallel within academic programs. We evaluated our practicum a few years ago at BCC, and in our lit review of nursing practicums that aim to teach about population health, primary health care, most of them are working outside of the health sector because the health sector isn't doing this work necessarily. And so, and then of those programs, practicums, most of them are offered at the individual and small group level of that Ottawa Charter framework. And I think there's a real gap and a real opportunity and need for us to be developing practicums that educate our students in community organizing and policy advocacy work. And so I think that there's a need to be scanning programs and looking at how are we developing our curriculum and practicums in that area. On the right here is a study that was done last year by Yassiatel, looking at scanning 76 public health programs across 26 faculties in Canada. And they found that around how are they taking up the curriculum and teaching research approaches, and they found that there was a 6 times the number of quantitative versus qualitative methodology courses in their population health, public health programs. And I think that also speaks to the need for balancing the dominant focus on epidemiological studies, and which are of course important, but the need to also balance that with critical participatory action research and critical qualitative research to be looking at those complex interrelations amongst these different factors, and then how do we engage in upstream action on the determinants of health. As I mentioned moments ago, there have been several reviews coming out over the last handful of years looking at the barriers to advocacy. And actually, I should mention, please feel free to jump in if folks have questions or comments. And so there's been several barriers, as I'm sure most of us on this call are very aware of, you know, from the frontline workload issue to where in nursing, as an example, our workloads have increased so much that there isn't time and space to be engaging in aligning our nursing work with wider organizing and advocacy. The insufficient educational preparation, as I've mentioned, and lack of support of ongoing professional development within this type of work have been identified in these reviews. Organizational constraints, the culture, the individualistic culture, which mirrors that broader neoliberal culture within our wider communities, the lack of awareness of the social determinants of health, and the challenges of collaborating, as we know, across different sectors of care is an ongoing challenge. Another barrier identified within research, as I've mentioned, is the dominant focus on quantitative approaches to research that depoliticize health and decontextualize it. And then this piece here, which was written just a couple of years ago by Graham and Sebald, I found that by following up on a mention by Don Nutbeam at our forum at SFU, talking about the health promoting hospital movement, which I wasn't actually aware of, but that was also in the works of the late 1980s work to envision healthcare and health promotion from an upstream social determinants of health and primary prevention perspective. And in this piece, they were talking about another barrier around funding and the tendency to well, the lack of funding and acknowledgement that hospitals can play an important role in primary prevention and health promotion. And I'll just refer you to that article to read more about that. In nursing, there are glimmers of hope and various different, you know, a handful of models that I have been wanting to get my mind into and reading more about. And I'm not going to get into them in depth here, but I just want to highlight a few. There's the Nurse Family Partnership Program. This one here, the Ontario Social Determinants of Health Focused Public Health Nursing Initiative, is also, I think, a really important initiative, and there has been some evaluation done on that initiative that is important to look at. This piece here is a study that was done, a case study review of that initiative, which included, and Abe, perhaps you can speak to this, 72 nursing positions were funded. And then the study, they engaged in 42 interviews with different stakeholder groups, reviewed 226 documents. And one of their main lessons learned in that, and this I don't think is new, is that to engage in equity-oriented social determinants of health-focused work, we need to be working at all levels, engaging multiple stakeholders, both within and beyond the health sector. So that is definitely an ongoing contemplation. This slide is a perhaps too messy of a slide, but it's a mind map in striving to start to map out how, in this case, nurses, but I am very curious to explore with members on this call how we can expand this out, or how this interrelates with the work of other disciplines in their primary prevention and health promotion work. And this is an attempt. I'm not going to get into this in more depth. I'm going to actually move into a series of slides. This is an outline for the next series of slides, looking at the various levels of work that, in this case, nurses can be engaging in, aligning their frontline nursing work with multi-level health promotion work. And I'm going to go into this in a bit more depth in the next series of slides. This is the same message, but in a different format. Looking at the continuum of opportunities for aligning nursing work with primary prevention and health promotion work. So I'll just refer us to this momentarily. So starting off with offering compassionate care, not blaming people who aren't able to follow through with healthcare advice, which is a tendency, stigma and discrimination that can happen. The lack of understanding of the context of people's lives is absolutely an ongoing issue within our health system. Next level being referring people to community and social services. How does referral happen within our health system, and linking people to those supports and services? And then, of course, we know that those supports and services aren't enough. So we need to be engaging in that wider advocacy, as John spoke, I think, so powerfully too. And that is so I think the next level of linking that needs to be happening is linking people to community organizing, mutual aid and advocacy groups that are engaging in upstream equity-oriented policy advocacy. And there are many, and I've noted a few here in BC, the First Call, Child Youth Advocacy Coalition, and the Poverty Reduction Coalition, both of where I had the privilege of meeting John. We then also want to be engaging in outreach, and this is another primary way that the health system, I think, tends to, well, not I think, has been shown to be the primary way that the health system is extending and addressing equities by bringing our health services out to marginalized communities. We then want to be developing and implementing prevention and health promotion programs, and that's done in various ways. Dennis Raphael, he's written a lot within the field of population health, public health, and is arguing that we really need to be engaging in wide public awareness building initiatives like critical health literacy, educating the public about the social determinants of health, like we did with the participation movement, and educating about behavioral approaches to enabling people's health, like eating healthy and exercising. The next level of work that we can be engaging in is positioning ourselves as thermometers of social suffering, to quote Waldegrave, and this is a group working to develop equity-oriented family therapy out of New Zealand. And I'll share a little bit more about that in a moment. And then the final kind of level of work that we can be engaging in interrelation with these other levels of work is collating evidence to inform community organizing and advocacy work. And then, of course, our health equity and surveillance monitoring, epidemiological research, looking at those broader trends, and critical health promotion research to be helping to inform our advocacy work. So now breaking that outline up into the next series of slides, if we go back to, again, frontline work, again, I would be so curious to hear what other disciplines are finding within their fields of study in terms of how to address the stigma and discrimination that is a part of our frontline practice, and how do we work against that. And there's a lot of work that has been done. I really appreciate ABE for reminding me to have a look at the Equip Healthcare work, and they have been doing and engaging in various research projects to look at how to be engaging in equity-oriented healthcare. And then there's important pieces of research like this piece by Diana looking at how to be countering social discrimination of folks who are lower income within our health systems, and increasing empathy and compassion and trauma and violence-informed care at the front lines, and how that's a very important part of this multi-level work that we need to be engaging in to be addressing determinants of health. Next level would be linking people to inter-sectoral supports, and that happens in various ways, and something that I am increasingly ongoingly curious about is how should different disciplinary team members be engaging in that work? And over the years, I've seen that being taken up variously. Patient navigators, cultural brokers are various terms I've heard. And speaking to that, of course, we have our discharge planning processes that happen both within the hospital system and beyond. How does that work get done in a good way to be linking people to existing supports? And who should be doing that work, I think, is a really important question to be digging into and exploring. And then, should that work be paid? Should it be done by various different interdisciplinary health workers or on a voluntary basis? Then there's linking people to community organizing and policy advocacy processes. And this is something that I don't see us doing in a consistent way, certainly not in nursing. I would be curious about others in different disciplines, perhaps more so in social work. But one example that I share with students out of VCC is that the notion of linking the people's stories that we hear and that we witness on the front line and updating them and informing them about wider community organizing and advocacy work that is happening, like BC First Call. Every year they offer, they work on and develop and produce a child poverty report card. And every fall at our coalition meetings, they invite the members that they're working with, the people that they're working with, to support in our community to share their stories and their personal narratives. And they do include a mixture of narratives of people's lived experience and grounded experience of poverty in their report card. And so that's a curiosity. How do we link people to those organizing and advocacy processes in a meaningful way? But then, of course, many folks either aren't interested or are too busy surviving, so they're not able to. So then how do we, as health workers, engage in that work? I'm just going to check the chat box here. Relationships, through relationships. Yes, right on. Thank you, Emily. So the other, actually, I'm going to jump ahead here for a moment. I think the other way of doing that is, and I've seen this variously, and I'll pull out a book here by Ryan Bielli, who has written a book sharing about what he's witnessed on the front lines as a primary care physician. And so how do we position ourselves as thermometers of social suffering or bearing witness to the wider, the impact of the wider determinants of health on people's day-to-day lives, and by attending ourselves and joining coalitions and community organizing and policy advocacy that is happening in our wider community among our civil society partners and our Indigenous leaders and groups to address these various interrelated issues. So that's another question that I think is worthy of contemplating. And how do we do that work in a non-paternalistic way and an ethical way? So how do we do that when we're wanting to share people's stories that we're witnessing? How do we do that in a way that's protecting their confidentiality or sharing their identity if they do want to be named? How do we do that in a way where we're not speaking on behalf of and not really actually honoring what people prefer in our communities, and imposing our own notions of what should be happening in policy advocacy work? And to go back to the Green New Deal, one of the things I appreciated in having a look at the documents, thanks to John for sharing them with me, this Our Time for Green New Deal, for example, is one of the coalitions that John was speaking to. And one of the notions that I really appreciated is that we need to develop a made in Canada Green New Deal. And that means that, we don't have the answers yet. We still need to be engaging actively in our community to figure out what that Green New Deal should look like. And I appreciated John sharing Noam Chomsky's careful words, some version of a Green New Deal. So we need to be thinking through how to be developing it in a way that is honoring the lived experience of the diverse members in our community. So I think that's something I would really love to explore with all of you, how we do that. This is just a slide to note the links, just to name how do we align organizing and frontline practice. That's a big source of contemplation that I'm curious about engaging with all of you. So to go back a few slides, outreach to marginalized communities. This is a review that was done by Andrew McNeil for his master's thesis. He reviewed, it was close to, I think, 2,200 health interventions across regional health authorities in Canada and the Northwest Territories, and then categorized what percentage of them engage in equity-oriented action, and he found that about 25% of health interventions were equity in nature, and that less than 15% addressed structural determinants of health directly. He found that most of them entailed bringing services out into marginalized communities, people facing institutional barriers, which is great and important work. And I think is a part of that multi-level action that needs to be happening to be addressing determinants of health. And so these are a couple of examples locally here in Vancouver. The Richer social pediatrics team is doing some incredible work bringing pediatric services out into the inner city, for example. This is an example of a pilot that we've partnered with out of BCC with some groups here to educate young people about the determinants of health and how to support them in engaging in action. And I think that's the kinds of prevention and health promotion programs we need to be looking at developing to balance the tendency, and I'm not sure if all of you would agree, but I find that the tendency for prevention and health promotion within my area in child and youth mental health nursing tends to be focused on teaching kids how to manage anxiety and depression, and not linking that to the ways that broader determinants of health are impacting their mental health and how to get involved in wider action to address determinants of their mental health. So again, like now the other wider piece to this work in terms of if we look at the levels of the Ottawa Charter for health promotion at that individual small group, building community capacity, and then wider health equity oriented policy advocacy work, this is another piece to the work, is how do we support frontline health and social service providers in engaging in ongoing scanning, policy scanning of the social, political, and economic trends that we're facing. How do we support them to stay up to speed on those broader trends? And then again, how to be linking their voices in those more traditional policy advocacy strategies and approaches like briefing notes and op-eds, position papers, engaging the media. In our program, we do have a health policy course, and we do offer our students an introduction to those ways of bringing evidence into our advocacy and the advocacy cycle. And then how do we engage in those broader community forums, town halls, public engagement processes, and how do we do that in a good way, both as healthcare providers, but also supporting the members of our community that we're working with to be engaging in that work. And then so many research implications for this work in terms of engaging interdisciplinary professionals in full scope health promotion practice. Like these are some of the questions that are coming to my mind. Should health and social service providers be engaging in full scope health promotion practice as part of their formal roles and responsibilities? Or should especially the wider engagement in socio-political action, should that be left to one's role as a citizen? This is a question I would love to explore with all of you. And if we do think that it should be part of our formal funded paid roles within the health sector, what is the rightful role of each disciplinary team member along with formal health promoter positions in health promotion practice? How should that be happening? And then what are the curriculum needs, barriers, and opportunities within our post-secondary educational systems? And then how do we address the barriers in the health system, like our increasing workloads, narrow job descriptions, and the wider organizational constraints that have been identified in the reviews over the last several years to looking at barriers and opportunities to equity-oriented advocacy?